Hello and welcome to the University of Washington, Washington Area Cardiometabolic Echo Session 3. I'm Nicole Ehrhardt, one of the adult endocrinologists at the Diabetes Institute. And today I'm excited to give you our third lecture, which will be on older diabetes medications and also set the stage with how to look at all classes of diabetes medication and individualizing these medications based on individual patient characteristics. I'd like to now introduce our panelists today. So Paul Chukowski is our adult psychiatrist and works particularly with diabetes. We also have Savitha Subramanian, who is our adult endocrinologist at the Diabetes Institute and also our lipid expert. We have Nyan Aurora, who is our nephrologist and also diabetes expert. And finally, Allison Bruner, who is our CDE. I'm going to go ahead and start lecture 3. My disclosures are, I've sat on the advisory board for Novo Nordisk and Dexcom, and I've received investigator-initiated grants from Dexcom and educational grants to support these great programs from Merck and Novo Nordisk. So what are our objectives for today? Our objectives are to be able to describe the different oral medications available for the treatment of type 2 diabetes, and then discuss the mechanisms of action, efficacy, and side effects. And what do we really want to do? We want to translate the use of these medications to those with our comorbidities, including diabetes, cardiovascular disease, renal disease, and liver disease. So before we talk about any medications, what we have to talk about is the cornerstone of diabetes, which is lifestyle and lifestyle modification. So I really do consider any medication therapy an adjunct for lifestyle. So we really want to highlight that and couple any medication changes to hopefully a small change for nutrition or activity at every visit. Why is that so important? What do we know? We know as little as 5% of weight loss can actually really improve our cardiometabolic profile. So beneficial outcomes for glycemic control, lipids, and blood pressure. And we know the more weight you lose, the more beneficial effects. Our goal typically is at least 7% or more sustained weight loss. Where did we get that from? Probably because of the diabetes prevention program, which showed that greater than 7% or more weight loss was very significantly shown to decrease the risk of developing overt diabetes. However, although it can be overwhelming to the patient, so you would not want to start telling them they need to lose 100 pounds or even 50 pounds. You want to make it a very doable goal. What we do know is that the more weight you lose, the more beneficial effects. So we may need to see 15% or more weight loss to see significant decrease in need for diabetes medications and other blood pressure and lipid drugs. The final thing we want to highlight is that yes, if the patient's goal is remission of their diabetes, you can tell them it is possible. And there was one primary care-led study that did show that with an average weight loss of 30 pounds, close to 50% of people developed remission for their diabetes. So again, what you want to do is to start small and use these things as motivational tools for your patients living with diabetes. Before we get on to insulin-sparing agents, the next thing I want to highlight is insulin, because there is this clinical inertia, especially around insulin initiation. And we don't want to be afraid to start insulin. And really, the American Diabetes Association and what is recommended for patients if you have truly uncontrolled diabetes. So average sugars greater than 300, fasting sugars above 200, which would equate probably to an A1C of 10 or greater. If they have catabolic features, so if they're losing weight, that's a serious sign. And also, if they have symptoms of severe hyperglycemia, like significantly increased thirst or increased urination, that is when you initiate insulin, because unfortunately, what happens is they're glucose toxic, so they're not going to respond as well to any insulin-sparing agent. So you treat them with insulin, then as the glucose toxicity resolves, you try to simplify their regimen and consider changing to insulin-sparing agents if possible. So the other thought process is once you start insulin, you don't always have to continue it, especially if it's a goal of the patient to be off of it. So really partner with them to see what is the best medication for them. Now going specifically in our insulin-sparing agent medications, I still show this slide, which first came out in 2015 because I was a young endocrinologist at the time. I was like, aha, metformin, guanines are first line along with lifestyle for diabetes. Then I shook my head and said, what should I do next? Over time, what has occurred is that we definitely have gotten more individualized recommendations on which insulin-sparing agents to use for our patients. That's basically the point of the next 3 lectures, is to look at how to individualize these different classes based on patient characteristics. What we're always going to highlight is that, yes, what we're talking about today is metformin, and it is still considered first line for our diabetes management. One thing the American Diabetes Association highlights is that when you do initiate insulin, you should not stop metformin. It's one of those things I see very commonly, is that people tell me metformin didn't work, that's why I started insulin. You don't want to stop the metformin, it just wasn't effective enough, but it definitely will decrease the cumulative insulin dose. So this is my first pearl. When you do add insulin, do not stop the metformin, because it will decrease the total daily dose of insulin need, okay? Then the other class of medications we're going to be talking about is sulfonylureas today. And the other thing I want to highlight is that when cost is an issue, sulfonylureas may be an effective choice. And so we'll talk about that more, about how to utilize them and what their risk benefit is in the next slide. Overall, when we're talking about individualizing individual medications for diabetes, what I tell people is these are the things you want going through your head each time you see a patient. If you know the mechanism of action, you can probably answer all the rest of these answers, but you want to know the mechanism of action, you want to know the efficacy, how strong of diabetes lowering medication it is. We know that more people are admitted to the hospital and go to the emergency room now for low blood sugars, especially in our Medicare population. So you want to ask yourself, how much of a risk for hypoglycemia is it? What I tell people is, remember, they're called anti-glycemic drugs. Even our drugs that have low risk for hypoglycemia, they all have a risk for hypoglycemia. Just that some have very small risk. We'll talk about that with every medication we look at. We know that cornerstone for diabetes management is if we can get some weight loss. So we want to know if these classes of medications help or hinder that other goal potentially that the patient may have and that you may have for the patient. We also want to look at cardiovascular effects, because that unfortunately is our largest killer. We know that cardiovascular disease is the #1 cause of mortality in the US. And then I think when people are less comfortable with, it's the use of certain medications in chronic kidney disease and in liver disease. So we're going to look at them and also see if there's any potential renal or liver effects. Then we all have seen this. Patient tries a medication for 1 or 2 days, but they have side effects, so they stop it. Even though it takes a lot of time, we really do want to spend the time counseling our patients on the most common side effects of the medication. We've also seen this where they come back to see you 3 months later and they've never started the medication because they saw something on the box label or they saw something on the television that made them scared to take it. So you definitely want to talk about the serious side effects so they're aware of the rare risks, but talk about it in a benefit cost ratio so that they understand that potentially the great benefit of this particular medication outweighs the small risk that you'll talk to them about. Another slide that says, yes, when my mentor did his training, there was insulin and maybe metformin and sulfonylureas available. Since I've become an endocrinologist, we have all these classes of medications. Another way I like to look at the different classes of medications is that we have so many different organs that we now target to help us with our diabetes management. So I like to look at it in multiple different ways. Because we're not talking about the classes of medications we use very rarely, I did want to highlight here our incretins, specifically our alpha glucosidase inhibitors, which commonly go by the trade name acarbose. Usually it's 30 milligrams before each meal. So I'm going to stop here and ask Savitha, is this a medication that you use in your diabetes management?
Acarbose, not really, but there is an indication for people with reactive hypoglycemia. Also, the cost is not that high in other parts of the world, like in Asian countries. So there's a lot more acarbose use, especially in pregnancy, but I don't use it in my practice at all.
Yeah. That's a great point. The few people that I've tried it on have been after a bariatric surgery having reactive hypoglycemia. The limitation of this medication is it tends to cause a lot of GI distress and issues with the bowel. So I have not had any luck keeping people on this medication, but you may see it for that reason. And I've had a few patients that utilize it that have come to me on it that have been tolerating it well. Additionally, there's another medication that we more commonly think about use for elevated prolactin levels, so bromocriptine, so our dopamine agonist. It's also under the trade name Cyclocet now for diabetes management. I'll ask Savitha one more time. Have you ever used this in your clinical practice?
Nope, I use it in people with prolactinomas, not in diabetes.
I just second that. I have never started it for diabetes management. It has been shown to improve the diabetes control. The next thing we want to highlight is that part of the reason why we're doing this discussion is that we have a problem with medical inertia, meaning that even though all these classes of medications are becoming available, we do not see a change in those living with uncontrolled diabetes, so A1C is greater than 9, or A1Cs making it to their goal less than 7. So that's why we're here all working together and partnering for this ECHO. And so now let's talk specifically about the two classes of medications we're going to be talking about today. So biguanines or metformin, which I think everyone is familiar with, but hopefully you're going to come away with some clinical pearls that are helpful to utilize it to best effect in your clinical practice. So our first thing is, what's the mechanism of action? What does metformin do? It decreases gluconeogenesis. So that's the big word for it decreases production of sugar in the liver. So what does that mean then? It just decreases production of sugar. Does it mean that it has a high risk for low blood sugars or a low risk? So it has a low risk for hypoglycemia, typically with extreme exercise or prolonged fasting periods. So it's something to mention to your patients, right? If during something like Ramadan, they're going to have long periods of fasting. So you may want to reduce the dose of metformin even if they're seeing any hypoglycemia during their fasting period. The next question is, does it cause weight gain or weight loss? If you think about it, it doesn't cause the production of insulin, so that probably means that it's a low risk for any weight gain. And sometimes you'll get as much as 5 pounds of weight loss associated with use of this medication. Every little bit helps, so it's good from a weight standpoint as well. The next thing to always talk to patients about is the common side effects. And the most common side effects are stomach upset, loose stool, diarrhea. My next clinical pearl is that probably 50 to 70% of patients who come to me saying they're metformin intolerant actually were intolerant to the short-acting, the 12-hour immediate release metformin. So if restarted on the extended release at a low dose, 500 milligrams daily, and slowly titrated every 7 to 10 days, if they're not having any significant GI symptoms, they typically can get up to that 1,500 or more dose that is effective for their diabetes management. That's my first clinical pearl. I'm going to ask Allison here, have you seen that in your practice as a certified diabetes educator?
Yeah, I have seen quite a bit of that with the non-extended release version causing more of the GI upset. And when patients switch over to extended release, they do better. Also, we see sometimes patients are just started too quickly on it. They just go straight onto a max dose from somewhere, and that can cause a lot of GI upset and make them think that they can't take it when they just need that titration.
Great points there. The next thing we're going to highlight is that, yes, what's great about metformin is it has good efficacy. So a 1% or more lowering of A1C. So for all those reasons, we like it. Now let's talk about the rare but serious side effect associated with it that sometimes can limit the use. I think we're always worried about metformin and risk for lactic acidosis. I think part of it is based upon the old FDA guidelines. There used to be a do not use if the serum creatinine levels were greater than 1.5 or greater than 1.4 in females. What happened then is that there was a large systematic review which then showed that the risk for metformin and lactic acidosis was very small and almost indistinguishable from the background rate in the overall population with diabetes. Then in 2016, new guidelines came out where they recommended that you could start metformin with a GFR less than 45, but at a reduced dose, and that you can continue metformin as long as GFR remained above 30, but not to continue it if it was less than 30. I'm going to stop there and ask Nyan, one of the most common things I hear is that metformin caused my kidney failure. So I want to ask you if you've heard that as well and what you tell your patients about that.
As a nephrologist, I hear lots of things cause my kidney failure, with most of which are not true. Metformin certainly doesn't cause actual kidney damage or reduction in GFR that's clinically relevant, similar to where we widely broadcast that SGLT2 inhibitors don't cause actual kidney disease. They're actually very beneficial. And with metformin in particular, the concern, as you're alluding to, is this lactic acidosis. It was much more common with fenformin before that was taken off. With metformin, it's pretty rare. I've seen it. These were in kind of overdose cases that I've seen it. There's probably some people with genetic issues with mitochondrial issues causing metabolism problem that can result in this. This is a very uncommon thing, and knowing the benefits of metformin, I do use it quite a bit, even in people with CKD. I mostly agree with this chart. My own opinion is that for people with CKD 3A, I do 1,500 milligrams a day, 3B a gram a day, and then I have used it in people with CKD 4 at 500, but I'm not opposed to people stopping it with eGFRs less than 30. That's my take on it.
Thank you for that insight. Great insight. The next thing we want to talk about is, what about metformin and liver disease? I find liver disease to actually be the most challenging because it seems like there's the least literature on this. But one thing they did find is that with metformin use, there is a reduction in hepatocellular carcinoma, overall mortality, and need for transplant. So it does seem to be a good medication to continue in those with mild to moderate liver disease. There was also a study that showed that it reduced the incidence of overt hepatic encephalopathy with the continued use of it. Metformin in liver disease is often held due to concerns for metformin-associated lactic acidosis. I will say that in my mind, what I've been doing until recently is continuing metformin in those that did not have child class C, and I put up the child classes just because I don't use them all the time, but truly decompensated and uncontrolled liver disease. There was a recent study that just was published in 2021 that looked at people with chronic hepatitis, and they actually showed, outside of renal disease, an increased risk for lactic acidosis in those with B and C. I am going to probably start to be a little more cautious in those that have child's B or higher, although it will be a risk benefit, especially if it means transitioning them to insulin, because insulin is usually the next step once you get to decompensated liver disease. I'm going to stop and ask Savitha if she has any insight on this and how she uses metformin in liver disease.
Now, with severe liver disease, again, depending upon degree of illness, with mild liver disease, I don't have any problems using metformin, but depending on how severe the cirrhosis is, yes, I would discontinue. I don't have anything more to add to that.
Thank you for that addition. So then what about metformin and cardiovascular risk reduction? I think most of us are familiar with UK-PDS, which is our largest complication study that they've now been following people for years for. And what did we learn from UK-PDS? That when you use metformin early, there was a decrease in diabetes-related death, all-cause mortality, and myocardial infarction. The number needed to treat to avoid one death was only 14. So that's a pretty significant number in my mind. However, what the caveat we have to say is that no other study has been able to show this potential benefit. When you look at the analysis of other studies with metformin use, what you see is a trend to cardiovascular benefit, but typically in those when metformin is started at a younger age. So how does that equate to my clinical practice? Definitely when we're talking about patients who have A1Cs of 7 that may meet the lifestyle goals for and no indication for medication management, I do talk about metformin as a potential early cardiovascular benefit, and especially in our high-risk patients living with prediabetes, such as those that have had gestational diabetes, have BMIs over 30, or are less than age 60. I at least have a discussion about metformin use, not only for the glycemic benefits, but maybe for that early cardiovascular benefit. And finally, my summary of the pearls that we talked about: try again low dose metformin extended release. Do not stop it if the eGFR is greater than 30, and you can start it if the eGFR is greater than 45. It's probably the one thing I want to highlight most. And we heard from our nephrology specialist that even at a low dose of 500, you could maybe continue it even with a GFR less than 30. We like this medication because it's not cost prohibitive, there's a low risk for hypoglycemia, and it causes slight weight loss. So the other thing to highlight is if you start insulin, please continue it. It may have cardiac benefits, and then continue early use of it in the appropriate population. Now let's go on to our sulfonylurea use. So when we're talking about sulfonylureas, how do they work? The short way of thinking about them is they sort of flog the pancreas to produce more insulin. So they're constantly stimulating insulin production. So what does that mean? It means that unfortunately they do have a significant risk for hypoglycemia. What this tells me is that glyburide now has a higher risk for hypoglycemia. So I tend to typically use glimepiride or glipizide in my population if I'm choosing sulfonylureas. Now, I tend to preferentiate glimepiride over glipizide because there is some slight benefit for first phase insulin secretion with glimepiride when you look at the studies. What does that mean? It means that it causes a little bit more insulin production after the meal. That's when we need it, right? In response to the higher glucoses postprandially. That's why I tend to preferentially use glimepiride over even glipizide because of that little benefit. This is also the reason this might be a clinical pearl. Some people are not comfortable doing that, but at a reduced dose of glimepiride 1 to 2 milligrams, I will still continue it with basal insulin because I do believe that it does have a little bit of that help with the postprandial glucose, which you don't see as much benefit just with basal insulin initiation. A cost-effective or more cost-effective therapy may be metformin, a low dose of glimepiride, and appropriately dosed basal insulin. The other thing we like about the sulfonylureas is that it is a very good medication for lowering A1C. You do get a 1 to 2% lowering of A1C. Remember as well that the higher the A1C, the more A1C lowering you're going to get up front. As well, it has a low side effect profile, except for, of course, that risk for hypoglycemia, which no one wants. And those that have a lot of GI issues, it doesn't affect the GI tract. Of course, there is the risk with all medications, but perhaps a little bit more with sulfonylureas for allergic reaction. There is about a 20 to 30% crossover with our sulfa drugs. So we want to really think about that if we're initiating someone with a sulfa allergy. Our next thing is, what is its efficacy when you add it onto metformin? Because that's usually what we do. I wanted to highlight this slide because it's about a 0.8% reduction, and that's pretty similar to basal insulin, so a lot more cost effective. When you're deciding between the two, as long as the person's not glucose toxic, it is something to consider. How do I use our sulfonylureas in renal disease? As we discussed, we really don't want to use glyburide in renal disease. And with glimepiride, I tend to start at a reduced dose, 1 to 2 milligrams for stage 2 to 3. When you get to stage 4, which is a less than an eGFR of less than 30, I typically will stop it. That's when we'll just use the short-acting glipizide at 2.5 daily, or maybe at most 2.5 twice a day. I'm going to stop here briefly and ask you about prolonged effects from sulfonylureas you've seen in your renal disease patients.
We see this all the time. As a nephrologist, I'm not a fan of sulfonylureas at all. I understand the need. I think we have better drugs, but I understand that in some patients, access, cost, et cetera, is an issue, so people need them. If they're being used, I really prefer glipizide. The rationale for that is it's metabolized in the liver into inactive metabolites, so it doesn't have the same effect in people with reduced kidney disease or reduced eGFR. We've seen patients with hypoglycemia for many days. There's case reports up to 10 days of hypoglycemia, which I haven't personally seen, but they're out there. And the problem is sulfonylureas are very protein bound, so we can't just dialyze them off. And so this can create a huge burden on patients in the hospital. So I try to avoid them. If it's unavoidable, I use glipizide.
Thank you very much, Nayan. And Paul, I just want to bring you into the discussion. Tell us a case of someone who's had a severe hypoglycemic event, maybe even a seizure, and what's some of the things that they've had to talk to you about, and what are some techniques to help them overcome the fear of hypoglycemia?
Over the years, we've had many patients who have difficulty differentiating between panic attacks and hypoglycemia. I'd say that's one of the main take-home points, is that hypoglycemia is often mistaken for panic attacks or vice versa. It's always important to distinguish the two. What happens with a lot of individuals is they develop fear of hypoglycemia and they almost get obsessed with not having lows and keeping their A1Cs high. There is an approach, a systematic desensitization exposure that they can do with a psychotherapist like we have in our clinic to work on fear of hypoglycemia. So that is something to consider. I think that we have to allow people to express their concerns and fears and maybe challenge their concerns. They may have some cognitions that they're catastrophizing about the possibility because they've had a horrible incident. I've had many patients like this, and so it's important to treat any depression or anxiety as well that might be exacerbating their catastrophizing or their fear of having another attack. And again, we don't want to invalidate the possibility, but we should also identify any comorbid conditions that are contributing to that.
I think that's a great point in people with fear of hypoglycemia to use your mental health resources to support them to come up with techniques where they can be desensitized and come up with good balance between their diabetes and their diabetes distress. So great points, Paul.
Thank you.
I wasn't actually going to mention the metigloinides, but I did have a patient just last week on these short-acting secretagogues, and they work a lot like the sulfonylureas, but they just have a shorter on offset. The benefit of them is they're less cleared by the kidney, and so things like the repiglinide or Prandin, supposedly at stage 4 or 5 kidney disease, you do not have to do the same dose reduction. Although I was looking at the literature, and there was one review where they looked at them as compared to sulfonylureas, and at the higher degree of kidney dysfunction, there was still significant hypoglycemia. I just do want to mention them in people who need just a whiff of a medication that do not want to be on insulin. You could consider using this in your later stage of kidney disease. Nayan, do you ever see people on metigloinide or repiglinide?
Yeah, I've seen people on repaglinide, but that's the only one. I don't have a ton of experience on it. We haven't had patients that I know of in the hospital with similar hypoglycemic episodes. That doesn't mean it doesn't happen. We just haven't seen it.
Great, thank you for that. Just in summary, our main risk of our sulfonylureas are hypoglycemia. And when we're looking at them with liver disease, unfortunately, there has been an increased risk of cancer. So in general, in liver disease, you want to avoid the sulfonylurea. Again, there's limited literature, and so I just will highlight that. And what about sulfonylureas and cardiovascular mortality? I think sulfonylureas got a bad rap because of first-generation sulfonylureas, which we no longer use. We're now using our second and third generations of sulfonylureas. In our first generation sulfonylureas, there was this thought process that they could cause ischemic preconditioning, meaning they could increase your risk for cardiovascular events. However, with our newer generation sulfonylureas, they actually have shown no increased risk for cardiovascular events. And also, what was interesting in this particular meta-analysis, the non-fatal macrovascular outcomes actually slightly favored the sulfonylurea use. So it's something to think about. And I think the other thing is that we'll learn more about the DTP4 inhibitors in one of our next talks, but what they did is they took a look at glimepiride versus linagliptin and risk of cardiovascular outcomes. And they basically found that as compared to the DTP4 inhibitors, there was no increased risk for cardiovascular effect from the DTP4 inhibitors or the linagliptin. So I think this great prospective study over 6.3 years on average does show the safety profile of this particular medication, at least from a cardiovascular standpoint. My overall summary is, remember, when you use basal insulin, definitely use metformin and consider continuing glimepiride in the appropriate patient population. Use glimepiride if possible, as it has more post-meal benefits. In renal disease, if the GFR is less than 60, start at 1 milligram of glimepiride. If it's less than 30, then use a short-acting glipizide. Really use with caution because of the risk for hypoglycemia and the sustained hypoglycemic effects. Unfortunately, it does cause some weight gain because it clogs the pancreas to produce more insulin, and insulin doesn't help us lose weight. And there's no cardiovascular benefit, but there is potentially no harm. What we like about it is it is cost effective, but we always have to just remember the risk for hypoglycemia. So I'm going to stop there, and then I'm going to ask Allison, is there any question that you want to summarize that was particularly helpful during the chat and everything?
There's been a couple really good questions in here. One of the questions was, if you have a patient that's on glipizide and they're uncontrolled, do you try switching them to glimepiride, or do you focus on different changes?
I would say that the efficacy is about the same between the medication. So I would probably still switch them, but if they're not maximized on the sulfonylurea, I would maximize it unless they had an increased risk for hypoglycemia, but I would probably add a second agent along with switching over. This is more personal preference. It just helps a little bit. We're going to move on to our case discussion and case presentation.
Thanks, Nicole. This is Tom Chin. I'm a family doctor at Health Point at the Bothell site. Today, we're going to talk about a 57-year-old Mexican man who's had a 7-year history of uncontrolled type 2 diabetes, whom I've been seeing for about 6 years. His other problems include high blood pressure, some chronic back pain, and a history of tobacco use. Currently, his main problem is A1C has been uncontrolled for quite a number of years. Currently, his medications include empagliflozin, 10 milligrams once a day, which was just recently started, liraglutide at 0.6 milligrams subcutaneously was started earlier this year at the beginning, but then he developed some back pain as a result of it and discontinued it. But then through recent conversations, he was willing to try it because it was the only affordable medication in that class for him. He's been on metformin, 1,000 milligrams twice a day for many years, and also on a long-acting insulin for many years. Currently, he's at 16 units. When he first started out back in 2016, it was about 12 units, and he peaked at 24 units. Within the last 2 months, through our pharmacy, he was able to be prescribed a Freestyle Libre 2 flash glucose monitor. Currently, he's on his third monitor. The results of his first 2 monitoring sessions reinforced the fact that his glucoses were high, but now I think he's starting to understand how to use the device better to get lower numbers. I've asked him to check his sensor with his smartphone after waking up, for meals, 45 minutes after finishing meals, bedtime, and at other times as he wants. He's been on lisinopril 40 milligrams once a day for the last 3 years, pravastatin 10 milligrams once a day since 2016, and occasionally he takes naproxen 500 milligrams twice a day as needed. The only allergies he has is to codeine with respect to a relevant family medical history. His mother and maternal grandmother both had type 2 diabetes. Fortunately, there's no extensive family history of heart disease, though he did say that his dad had some heart valve problems that necessitated surgery to fix those issues. In terms of his social history, he's worked as a roofer for many years. He's now a project manager for his crew. He has a GED. He's married, has 2 kids. He used to smoke, but quit about 5 years ago. In terms of his vital signs, he's normal weight and his blood pressure is under 140/90, though ideally, of course, it should be less than 120/80. His most recent lab values showed an A1C of 12.3 with a corresponding glucose of 263 in a fasting state. He's got normal renal function and thankfully normal lipid profile. His urine for microalbumin was also normal. His liver function tests were fine. Below here, you can see his A1C history, which started out okay, pretty bad at 10.2 in January 2016, got better into the single digits throughout that year, but then in 2017 went up to 11 and it has stayed in double figures ever since. This was his first CGM weekly report. Fortunately for him, with the help of our pharmacists, they have the patients come back in 2 weeks so they can download the data, give the patient a printout, download a copy to the patient's chart, and do some counseling with respect to what the data means. You can tell here with this first CGM, he was off the charts with 58% of his values being greater than 250, and then another 38% being between 181 to 250. So that his GMI, glucose management indicator, though did register as a 9.6, so that was encouraging that at least that was starting to dip down into the single figures. The above is just the graphical representation of those numbers. This is the second CGM report here between March 28th through April 18th. He was still struggling. 92% of his values were in the very high category of greater than 250, with another 8% between 181 to 250, and it didn't have a GMI for whatever reason. At the same time, notice that his time that he's scanning his CGM, the percent time the CGM is active, was low at 45%. Most recently, when I had a chance to talk with him in late April, and that he had a third CGM only for a day or two. He did report that his before breakfast number was down to 120, and then 30 to 40 minutes after breakfast, it was 160. Before lunch, it had gone up to 179, and then 30 to 40 minutes after lunch, it was at 145. His average glucose, he told me on the phone, was 162. The time in range was 78%, and he wasn't having any hypoglycemia problems. His last office visit was March the 7th, during which time the MA did a foot exam. He saw an eye specialist sometime in 2021. He told me he had depression screening 2 months ago at that last in-person visit. The last time he saw a dentist was just this April. In terms of diabetes education at our facility, mainly we send them to our registered nurse for that, because a lot of patients, especially like him, who don't have insurance, they can't afford to go to the information-rich sessions that are presented at local hospitals. His visit with the nurse obviously was quite a number of years ago, back in 2016, as was his visit with the dietitian in 2016 as well, down there. The problems that he's had is because he works outside, over the years, he's not really wanted to take any medication at lunchtime. That's restricted some of what we've been able to do. He was agreeable to start insulin, but he only wanted to inject himself once a day. We started with the basal insulin. I talked to him about maybe starting some mealtime insulin earlier this year, but he still didn't like that idea. He's done some finger stick measurements, but not a lot. So that's where the CGM is really helping him, to give him a lot more data. The good news is it is within his budget. If he needs to purchase the sensor at our pharmacy at a cost of $75, he said he would be willing to do that. That's basically his story. In terms of meals, he has gotten better over the years. Asked him about his eating most recently within the last couple of weeks. This is about as low in terms of carbohydrates as he's ever eaten. Breakfast is a coffee and then one slice of trans keto white bread, which only has 12 grams of total carbs with a little bit of butter. Lunch, he used to buy lunch at fast food places or food trucks, but now he brings his lunch. His lunch recently consisted of 2 hard-boiled eggs, 1 cup of green beans, 4 small keto tortillas, which he ordered from Amazon.com. So each of these street taco-sized tortillas only has 3 grams of total carbs. The cup of green beans was 11 grams of total carbs. A dinner consisted of 4 ounces of homemade barbecue beef with red chilies, a 1/4 cup of beans. The beans have a total carbs of 10 grams, and then 10 baby carrots, the total carbs of 8 grams. And nothing after dinner, no snacks. But he's never been a snacker anyways, which has helped him in that regard. Because he's so tired after 8-9 hour days as a roofer, he really doesn't have much energy or incentive to exercise, but he does get a lot through his job. He doesn't have any problems with his sleep, but he recently shared with me that he's been stressed out about his wife's immigration status. Her dad fell ill and she had to go back to Mexico. I think she stayed there too long. So then that caused some problems. He didn't give the specifics and I didn't know exactly what to ask. I did give him the name of a friend who's an immigration lawyer whom he said he would try to contact. So hopefully that will work out. That's been something that he hasn't shared with anybody. With that stress, it would be impacting his glucose to some degree.
Tom, great presentation. I will ask Savitha if there's any other clarifying questions the group has done. What I will say first is that for glycemic management indicator, you have to have 2 weeks of data, so it won't report that estimated A1C or glycemic management indicator unless you have greater than 14 days of data, because that's been correlated with the best association with serum A1C. That's probably why it wasn't reported yet, because he wasn't at 14 days, or he didn't have 14 days of use. It might have fallen off like a day or 2 early. I didn't see the duration of that particular one.
That was very helpful, Dr. Chin. Thank you for that presentation. I'm going to summarize summarize the case that Dr. Chin very nicely presented. So we have a 57-year-old male of Mexican heritage who's had diabetes for about 6 or 7 years. Almost since diagnosis, except for a short period of time, he's been severely hyperglycemic, at least based on his A1C levels. He has had A1Cs pretty much ranging between 10 and 12 for the last 2 to 3 years. He has no microvascular complications. He has a BMI of 24, so fairly lean. He quit smoking 5 years ago. He's a roofer, as we heard, and he is uninsured, so he pays for his medications himself. He also has treated hypertension. He has low back pain and looks like he might have a low HDL cholesterol. We didn't see untreated lipid levels there, but that's okay. His diabetes regimen is multi-drug and fairly complex. Metformin, empagliflozin, the lowest dose of liraglutide, and then once a day of detamir. And he also takes lisinopril for hypertension and pravastatin. Let's break this down. Diagnosis, it looks like this gentleman likely has type 2 diabetes, as it will become apparent as we go through the CGM data again. And general goals, of course, he's been chronically hyperglycemic, so Dr. Chin has been working with him appropriately to educate him, counsel him about the ill effects of hyperglycemia. So general goals are to slowly get him down to make sure he's adherent to his medications. He's taking his injections, non-insulin injections, as well as his insulin injectable as he should be. That's an important thing to reinforce at every visit. For general goals, I'd also emphasize it's important to build that trust. And sounds like this gentleman and Dr. Chin have built a good rapport. This rapport building is very important in taking care of our patients with diabetes. Social determinants of health and behavioral health. I didn't hear any mental health issues that were raised during the presentation, but he is uninsured, so he pays for his own medications. It sounds like he has a job, and there's been some family stressors with his wife. So maybe involving social work, if there's that support available in your clinic as necessary, at least offering it would be helpful. A1C and glucose goals, as Dr. Chin has been working with the patient, he's been in double-digit A1Cs for at least 3 years. In folks like that, it may be reasonable to set an interim goal rather than say you need to have your A1C at 7% now or yesterday. I usually like to say, okay, let's try to get you down to 10% first, then slowly reset the goal every 6 months or so. We'll talk about suddenly dropping blood sugars in somebody who's been chronically hyperglycemic. And we'll talk about medication therapy and adjustments. Dr. Ehrhardt will highlight that.
It is something to think about. We saw such a dramatic change in his continuous glucose monitoring, and it looked like from both his recent dietary recall and also potentially he's already on a significant amount of anti-hyperglycemic meds. But what it looked like to me is potentially he increased in comfort, especially with his very active job in taking all his medications. So the CGM lifted that barrier of fear of hypoglycemia because he could monitor it. And also he saw the effect of that fast food, so he changed his diet. So that was my first question for Tom. Do you feel like he made these changes because of the CGM, or has it not been teased out because you haven't seen the follow-up yet?
I think part of it was he was frustrated that his A1Cs had been high for so long, but the CGM definitely helped because here he didn't have to hassle or have to do the job of sticking himself so much, and he could do it discreetly, and even when he was at work, all of those things helped. Yeah.
Do you believe he was taking his medications every day, including the basal insulin, the Victoza, liraglutide, and metformin? Or do you think sometimes he was skipping the dose, especially because of fear of hypoglycemia with long stretches of work?
I don't recall that he ever complained about low blood sugars. He was pretty compliant with his medications in general. I think what hurt him previously was he was just eating a lot of carbohydrates. And of course, he didn't have any information or much information to guide him as to how much his body could handle.
Mm-hmm. So you think most of it was nutritional changes based on the feedback he was getting from actually seeing his glucose. And I was just highlighting this. This is something I've heard in my patients who especially work in construction or are outside for large periods of days, they say they don't drink sugared beverages, but then for the electrolytes, they'll often drink Gatorade at work. So figuring out a way to talk about that in a non-judgmental way is great. I don't know if that's him, but it is something that I tend to bring up with people just because there is this thought process. And of course, the sports energy drink people have said, you need electrolytes. The body needs water. It probably doesn't need the electrolytes unless you are not in a fasting state or not eating anything for a large period of time. I think the small changes for his nutrition, when you look at his diet, I think he's already made a lot of changes, but that's sort of the heart of things. And then we did not see any issues with diabetes distress or depression, but because we have our mental health expert here, I was just going to ask him if there was a significant depression or anxiety component, especially with the immigration status. Have you found in the diabetes population any particular depression medication or class to be especially helpful?
So if this person actually did have a diagnosis of depression and it wasn't an adjustment disorder, in the case of an adjustment disorder, for example, related to stressors in his family with his wife, an adjustment disorder would just require some counseling and not require medication. But let's say, for the sake of answering the question, if he had an active anxiety or depressive diagnosis that required a medication, my usual approach in people with diabetes is to obviously avoid medications that would cause weight gain. So tricyclics, mirtazapine or Remeron, both definitely will increase weight. SSRIs and SNRIs, it depends on the person and generally don't increase weight a significant amount. Bupropion is either weight neutral or in some patients can help them to lose weight. And it's also been used together with naltrexone for weight loss. And then the other thing is that 25 to 50%, probably not in him, he's only had diabetes for 7 years, but they can develop neuropathy, as you know. And so then we have SNRIs, serotonin and noradrenergic reuptake inhibitors, such as duloxetine and venlafaxine, which both have been shown in clinical trials to help with neuropathy pain. So those would be considerations in people with comorbid neuropathy symptoms.
That's a great point. I've started to use the duloxetine, or Cymbalta is the trade name, more commonly in those that have peripheral neuropathy and chronic pain and depression, because it does tend to target. It also tends to be a little bit more weight neutral to weight loss, is my understanding of the literature. Great points there. Savitha, let's get back to the case.
So I'm going to go through this, what we call AGP report. And I apologize if many of you know how to interpret this, but I think this is basics of CGM interpretation. First of all, what is this device he wore? So he wore the Freestyle Libre, and that's that little circular patch on that woman's arm. It's worn on the back of the arm. What's the technology? So the sensor sticks to the skin, and there's actually a little filament. It's not a needle that goes into the skin, and it measures interstitial fluid glucose. So the chemistry on this is pretty similar. It's actually the exact same as the chemistry on a glucose test strip. So it's glucose oxidase. That's what reacts with the glucose in the interstitial fluid, and that's converted to a light signal. And I couldn't explain the technology too well, but it's converted to numbers, and that's what you get in a CGM reading. So for this particular device, the patient probably put the app on his smartphone, and anytime you want a glucose reading, that app is brought near the sensor and you scan it, and that gives you a glucose reading. The patient does this sensor stays on for 14 days on the skin. So it looks like that's what they do in Dr. Chin's clinic. So he came and he put one on for 14 days. He came back in and the first set of data was obtained. So the data that's downloaded is called an ambulatory glucose profile, or AGP. This is what it looks like for somebody who wears a Freestyle Libre. There are certain aspects of this that you need to know how to look at, because the Libre is actually a primary care product and it's available by prescription. You should get comfortable with knowing how to read this. Glucose metrics for CGM. This is all changing. This is the changing tide of diabetes. Lots of alphabets on the left side. The abbreviations are shown there. AGP means ambulatory glucose profile, and the report on the right is the AGP report. There are certain metrics that are used called time in range, or TIR. That'll actually be represented by green in the bar on the top right. And the GMI that Dr. Chin talked about is called the Glucose Management Indicator. That is a software calculated equivalent of the A1C. So it's not lab measured, but this is based out of international consensus, and there's an algorithm. So the GMI is actually based out of the readings that the sensor gets. I forgot to mention in the previous slide is that little filament that's in the interstitial fluid glucose measures glucose every 5 minutes. You can get 288 readings in a day. So that's what is amalgamated as this curve in the bottom. That is the AGP, or the ambulatory glucose profile. That shows you as a curve. It's like an EKG for blood glucoses. So that's what the patient has seen and has given him information. So what do you look at in this report? This is all standardized. Wherever you are, if you are able to download this, this is what the report will look like. The top left is what you want to look at first. This individual wore this for 14 days. And the CGM is active for 93%. So meaning you need to have, for 14 days, I think you need to have at least 70% of readings for it to be interpretable. You need to look at these numbers. And then if you move your eye to the bottom of that red box, there's average glucose. So that's the average glucose for the last 14 days. The GMI is given as 9.6. And I'm going to leave out the glucose variability, but you need to look at that first. And then on the right side is the big bar that you can show your patient. And the green part shows you, so he doesn't have much green, but what this should show is green, yellow, and orange. There should be lots of green, less yellow, and hardly any orange. Unfortunately, in his case, is a little reverse. Green is the time in target. Yellow is the time above target between 180 and 250, and the orange is above 250. So he has 58% of the readings above target. So he's consistently hyperglycemic. If you move your eye to the bottom of the screen, you see that glucose profile here. So that box time goes from midnight to midnight. And so you can see the curve. You can probably see, figure out when he's eating breakfast, somewhere probably 6 or 7 a.m. And then you see the curve going up for breakfast. And then you can see that curve probably going up for dinner time. This is what this curve shows. And this is probably what was very enlightening to the patient. As he was scanning, he was seeing what his blood sugars were doing. It's kind of like going from black and white to color. So very illuminative. So similarly, this picture is the second figure for this patient. So again, we're going to go through the same thing. Top left, you can see here 14-day data. Glucose CGM is active only 45%, not enough data. I'll tell you why this is in a second. So as Dr. Ehrhardt said, there's no GMI here because there's not enough numbers to give you a reading. And the average glucose for this period, based on whatever numbers there were, is 316. Very high, chronically hyperglycemic. You can see here, this is 92% high. If you move your eye to the bottom here, you can see that the curves are not full. This means that he's not scanning enough. So there's missed data. You have to scan every 8 hours to get data from that little circular patch that they're wearing, because that sensor can only hold 8 hours worth of data. If you don't scan every 8 hours, you're going to miss data for if you're out of the house or you sleep for 12 hours, you're going to lose 4 hours of data in the beginning. So that's the reason why there's not enough data here. So he wasn't scanning enough, but you can see whatever readings there are is pretty high. They're all in the 300 range, and that's what's shown here is the 316 average. This is significant hyperglycemia. He probably saw this, and then based on what we heard from the phone visit, things drastically changed, and his average glucose readings for the CGM was 120 compared to where he started in the 260 to 300 range. Everything is significantly improved, and this is likely because he started figuring out how to use it and what foods are doing to his blood sugars. We don't have the figure for this, but I want to make an important point here in someone who has been chronically hyperglycemic, years and years of hyperglycemia, A1C of 10, 11, 12. In this gentleman, it's at least since 2018. So it's 4 years of hyperglycemia. There is something called early worsening of diabetic retinopathy. When this happens is if there's sudden improvement in glucose levels in a person whose diabetes has been suboptimally managed for a long period of time, there is a significant worsening of retinal changes. If there were no retinal changes or they didn't have retinopathy before, they can get cotton wool spots. We don't understand why this happens. There are many hypotheses, but this has been shown in many of the type 1 diabetes trials. So it's very important to keep this in mind. This is not recognized as often as it should be. This is likely because of, again, hypotheses only, changes in osmotic pressure, changes microperfusion defects, but the retinal vessels get leaky is what you need to know. It can happen with sudden initiation of insulin therapy in somebody who hasn't been taking their meds or had been hyperglycemic for years and years. You get the signal in the semaglutide trials. There's a worsening of retinopathy. It's thought to be maybe because their blood glucose control is improved. And it commonly can be seen in pregnancy because in women who become pregnant, their glycemic controls become significantly improved because of the baby. This gentleman needs monitoring. He needs to be sent to the eye doc if he hasn't already. Keep this in mind. This is not something that's often talked about, but in his particular case, he's been very hyperglycemic for years. So you should have him go and get his eyes checked. I'm going to pass the baton to Dr. Ehrhardt here about medications.
Thank you so much, Savita. We're going to talk briefly about optimizing his medications. We think that from his nutritional changes, he's actually doing fairly well. An average glucose of 160s would just be over 7. So what can we do? Well, what we may want to do is try to maximize his insulin sparing agents while minimizing his risk for hypoglycemia as a construction worker, and maybe even further minimizing his basal insulin at this point. The point I want to make is it sounds like the empagliflozin has only been started in the last month or so, but he's only on a half dose of 10 milligrams. Typically, in a younger person that I'm not worried about dehydration, and him, because he works outside, I might have waited a month to make sure that he's not having any dehydration symptoms. But usually after 2 weeks to a month, I'll escalate it to the full dose at 25 milligrams if they're not having too much polyuria that's affecting their lifestyle, and hold it there and then monitor for any other side effects from the medication. I definitely think as long as he's not reporting a lot of polyuria or any urinary tract infections, it would be appropriate at this point to escalate the empagliflozin. I typically will check a renal function test about 2 to 4 weeks after I initiate it. Any comment on that, Nayan?
I would wonder what people would do with that renal function panel after however long you take it, because you know the creatinine's going to go up or GFR is going to go down by anywhere from 10 to 30%. As a nephrologist, we'll cap our empagliflozin or dapagliflozin at 10 milligrams because we know that from our kidney benefit, cardiovascular benefit, you only need the lower doses. If you're doing it for obviously anti-glycemic benefit, then I defer that to the provider primarily managing the diabetes.
Great point. And it is a weak glycemic agent. So if you have any in your more frail population or any risk for dehydration, then you might want to hold it at the 10 milligram dose. He is young, fairly healthy, and able to drink to thirst, so I wouldn't have a problem going up to the maximum dose. Now, I like to use extended release metformin just for ease for people. It sounds like this hasn't been a barrier for him. So again, an option might be to use the metformin at 750 milligram tablets, 2 tablets. Then the next thing is to think about is potentially liraglutide. Now, it'd be very uncommon for liraglutide to cause back pain, but what you always want to do is validate people. Who knows if he had a little work injury or a little sciatica or something. One thing I could think it would be associated with it is you do tend to see a slight increased risk for biliary colic with the use of the GLP-1 because it slows down the gut. I would guess that there was just unlucky timing with that back pain and the liraglutide. And we'll talk more about the side effect profile in the upcoming lectures. One thing you can think about doing with liraglutide is that because it's in a pen-like structure, even though there isn't doses midway point between the 0.6, 1.2, 1.8, to increase his comfort and to partner with him, you could do halfway dosing between the 0.6 and 1.2 for a week or two to make sure that he feels comfortable. That would be 5 clicks. There's 10 clicks in between each dose. So if you do 5 further clicks after the 0.6, you're going to get half again that much dose. That's a great way, although this would be off-label to utilize, but it allows them to build their confidence and minimize any nausea symptoms, which is the more common side effect. My thought is that you maximize the empagliflozin, maximize the liraglutide if possible, and then the next thing would be to take a look at the detamir. The first thing I wanted to highlight is when we're talking about basal insulins, Our clotted like glargine, we typically think of up to 24 hours. And so similarly with the detamir, levemir product, but really at the lower doses per kilogram, it tends to last less than 20 hours, a little bit more closer to how the NPH works. But I wouldn't necessarily want to use NPH because there's more of a peak versus the detamir has a flatter effect. Now, in this person's case, he weighs 160 pounds, so he's on only about 0.2 milligrams per kilogram, which is a good dose of insulin for someone who's working outside and has risk for hypoglycemia, but he's probably at a fairly low risk for hypoglycemia. And I actually think detamir isn't a bad choice for him because it's going to wane a little bit in the afternoon if he takes it the night before, just as he's been working harder, and it might actually reduce the risk of hypoglycemia. But I just did want to point out that you do want to think of detamir at doses less than 3 to 4 units per kilogram as a twice-a-day dosing, especially in those where mobility is limited and you don't want that waning dose of the insulin. The other thing I wanted to highlight is that it was explained to me is that he had the 305B pharmacy. So he does have access to medications at a significantly reduced dose, but not everyone has access to that pharmacy benefit. We'll talk about that more in our lecture on how to get medications for patients. One thing to think about is what could we use from the Walmart formulary that would be cost effective for him. In his case, I probably would use 2 tablets of 750 metformin extended release. I would use glimepiride at 2 milligrams, not too high of dose because of the risk for hypoglycemia. And in his case, because his BMI is lower, potentially pioglitazone or Actos is the other name. We'll talk more about this medication at the next lecture, but it is something to consider if he suddenly didn't have access to those more expensive insulin-sparing agents, which would be our preferred medication. And right now he's on a preferred regimen, but it's just something to think about because not everyone has access to those insulin-sparing medications. Now I'll give it back to Savitha just to make some brief comments about cardiovascular risk.
We're going to talk about lipids here and cardiovascular risk reduction in this gentleman with diabetes. So this gentleman is on low intensity pravastatin, but if you plug his numbers in the risk calculator, he falls under the intermediate risk, which is 7.5 to 20% 10-year ASCVD risk. So the recommendation is moderate intensity statin, and the dosing of moderate intensity statin, I'm sure you are all familiar, usually includes Rosuva or Torva shown here. Pravastatin at 40 to 80. He's at the lower intensity dose. That may be okay. His LDL wasn't that elevated, so it should be fine. Here's some pricing for the statins are all generic and so easily available. They're mostly $4 drugs, especially simvastatin, and atorvastatin also is a little bit higher in cost, meaning like it's $10 to $20 range, easily available. A few points, since we are cardiometabolic echo, I want to just point out this gentleman has a lower HDL cholesterol level, but that's very common, especially in people with diabetes. It's unusual to see isolated low HDL in the absence of elevated triglycerides, but it can happen. And when it does, it's most likely genetic. It can also happen in people who eat diets which are very low in fat. However, I want to point out that we don't really target HDL cholesterol anymore, meaning we don't try to raise the HDL cholesterol for reducing ASCVD risk. HDL itself is a hot button area of research. We don't really understand whether it's actually the HDL number or whether it's the functionality of HDL that we should be looking at. I wouldn't target the HDL cholesterol as such. He did have a low HDL. Dr. Ehrhardt wanted me to talk about aspirin in primary prevention in people with diabetes. Answer is not really needed unless they are very high ASCVD risk. And what does that even mean, very high ASCVD risk? Well, diabetes is cardiovascular risk. If somebody has added risks like CKD, higher BMI, significant dyslipidemia, that would maybe be a situation where you might start low dose aspirin. But the bottom line is you really don't want to give aspirin for primary prevention, especially if they're at high risk for bleeding, and definitely not in older adults over the age of 70. Before I pass it back to you, Nicole, I wanted to answer a question. It came from Dr. Riley about the retinopathy risk with sudden glucose reduction. The point I was trying to make is, so in somebody who's very severely hyperglycemic for years, I usually do gentle glycemic lowering. If they went from 300 to 150 or 160 over a period of 2 months, 1 month, and 6 weeks, yes, there's definitely retinopathy risk, so they need to be screened for that. So that's why in these kind of situations, I set interim goals and the slope should be a little bit more gentler. This gentleman, he did it on his own and it happened. So to prevent any retinopathy from causing vision loss, he just needs to be screened. So that's what I was trying to say with that early risk reduction.
There's some great other questions related to risk calculator. Because in diabetes, it's like over the age of 40, it's moderate or high intensity. Do you use a risk calculator, and how do you factor that in if you're using the risk calculator?
I don't think you want me to answer that question because I'm a lipidologist and I very seldom use the risk calculator. It has its place for use. It has some drawbacks because the risk calculator can underestimate risk. In general, I think the principles of what the risk calculator says, moderate intensity statin in people with diabetes is appropriate based on intermediate risk versus high risk, moderate intensity. I would go with that. The goal is, yes, to get the LDL cholesterol under 100 or closer to 70, again, depending on the risk factors. In general, you just need to have them on a moderate intensity statin. Thresholds may not be necessary unless their LDLs kind of hang out above 100 all the time.
That was a great summary. So just to clarify, so you feel like as long as they're on a moderate intensity statin, if that's their risk indicator, you do not target an LDL of less than 70. Can you comment on that a little bit?
Yeah, it depends on other risks. So our gentleman actually had hypertension also. So somebody who has hypertension, other risk modifiers, genetic risk, strong family history of premature cardiovascular disease. Those are situations where the genetics trumps the risk calculator. It doesn't actually show up in the risk calculator. So family history will be important to take. In those situations, yes, I will target the LDL closer to 70. Multiple risk factors in primary prevention in diabetes. Yes, there is indication for a high intensity statin, but if it's secondary prevention, of course, everybody should be on a high intensity statin if they can take it.
Does his smoking history make you target a tighter goal? He is 5, yes. And then the duration that he's not been smoking.
Yeah, so you can put smoking in the risk calculator, and I did, and he's intermediate risk because he's over 5 years of quitting smoking, and it doesn't change it. So it's already incorporated, and he's now ex-smoker, so it should be fine.
The final question before we end the session is, what about patients who have low LDL? You know, what if without statin therapy, they're in the 30s or 40s? Do you still use moderate or high intensity statins based on their risk?
Great question. So an individual who has a low LDL without treatment, an LDL of 30 or 40, likely has a genetic condition called hypobeta-lipoproteinemia, meaning they make very low LDL cholesterol levels. These are people who do not need a statin because people who have hypobeta have a genetic defect in making the protein on LDL cholesterol. Individuals who have this, if they don't have diabetes, actually have increased lifespan. So if you have low LDL cholesterol levels, there's an association with longevity. So no, if you have someone who has an LDL of 50 or 40 or even 60 on no statins, there's no indication to start a statin. However, if they have hypertriglyceridemia, that might change the risk. So there is a little bit of nuance there, but just for the LDL, no, I would not start a statin.
Great points, Savitha. And because of time, we're going to say this ends session 3 of the Cardiometabolic Echo.